topic for today is an interesting topic on day-to-day practice of hypertension that we do. We know that in the world today, uh, we almost have 2.6 billion people in the world globally who suffer from hypertension, and most of them have also got renal and other target organ damage because of undetected hypertension. So, hypertension is a global challenge, and we need to take care of this challenge, detect it early, and treat it early to prevent target organ damage. So the topic is on the therapeutic approach for managing hypertension with cardiorenal comorbidities. So half century ago, most clinicians believed that it didn't matter if there was a rise in systolic blood pressure, and if you were the age of 70 years, then 170 millimeters of mercury was a normal blood pressure for you. And this was the article published in BMJ editorial in 1935, which said that it's illogical to reduce blood pressure. But it's only later we realized that patient had proteinuria, patient had LV hypertrophy, heart failure, and strokes with a blood pressure of 170 in a 70-year-old. And then the whole change in the control of blood pressure became important. So blood pressure reduction of 2 millimeters of mercury will decrease cardiovascular risk by 7 to 10%. So 7% risk in the incidence of ischemic heart disease and 10% reduction in the risk of stroke makes it very mandatory that we need to control the blood pressure in our patients. This is only going to benefit to prevent end organ damage for hypertension in our patients. So, what are the global trends in hypertension? So, if you look at the number of people who suffer from hypertension and we don't treat it, so you take the high income Western region or the Middle Eastern region or the Central Asia region, and if you look at the red is the undiagnosed hypertension in the world. And if you look at the orange, it is diagnosed but untreated. And if you look at the light green, these are treated, but the blood pressure is not controlled. And if you look at the top green, that only forms 10 to 12% of this particular chart, which actually has controlled blood pressure. So if we have 2.3 billion people in the world who suffer from hypertension, only 10% actually have a controlled blood pressure. So we have a large challenge at hand. And if you look at the prevalence of hypertension in Oman and in the UAE and the Middle Eastern region, 30% of people suffer from hypertension. And high proportion of these patients have blood pressure in the hypertensive range. And then there is added problems of cardiovascular risk, such as diabetes and age and the body mass index with obesity, which makes it a challenge. So there has been a progressive increase in the prevalence of hypertension in Oman and the rest of the Middle East in the last few decades. So if you look at the Oman World Health Survey estimated that hypertension in Oman is 41.4% compared to 27%, which was reported in 1991. Now, 41% hypertension is really large number. That means if you screen 100 people in Oman, 40% of them are going to have a high blood pressure. This is also with the increase in the obesity and other cardiometabolic diseases such as aging and diabetes and obesity and change in the diet and the lifestyle in Oman, which is responsible for such a high incidence of high blood pressure. Also, Oman has a rich history of interaction with neighboring and distant countries in Asia and Africa that goes back to many thousands of years ago, and hence the Omani population is ethnically diverse. The country is wide. There is a young population of close to 30%, and with increasing affluence, with modernization, with non-communicable diseases, and risk factors such as obesity and also low level of exercise in Oman may be responsible for cardiometabolic disorders and also hypertension in this part of the world. So, early onset of hypertension is associated with hypertensive end organ damage. So, already by midlife, people develop end organ damage, which may be in relation to the brain, to the heart, and to the kidney, and also to the eyes. So these are the various complications that happen because of high blood pressure. So if you look at the heart, when high blood pressure is not treated, will lead to LV hypertrophy and heart failure. And if you look at the eyes, a retinopathy, or if you look at the brain, the incidence of stroke increases. And if you look at the kidneys, it does develop proteinuria and also chronic kidney disease. So underlying cause of hypertension may differ from the young versus the old. So if you look at both a diastolic hypertension in combination with the systolic, it may happen in young people, male sex, obesity and high BMI, and increasing BMI during follow-up. And the main mechanism here is a high peripheral resistance, which may be responsible for hypertension. But if you look at the elderly people with systolic high blood pressure, that's called isolated systolic hypertension, which may happen in old age. And this can be because of aging arteries, where the compliance of the peripheral arteries become reduced and the thickened aging atherosclerotic artery may be responsible in the elderly with isolated systolic hypertension. So this is a sympathetic overdrive in hypertension in all stages, whether you look at mild, moderate, or severe hypertension, or hypertension in the young elderly, or isolated systolic hypertension, or pregnancy-induced hypertension, or white-coated or masked hypertension, or obstructive sleep apnea-related hypertension. 24-hour ambulatory blood pressure becomes mandatory because you have dipping hypertension or extreme dipping or a reverse dipping hypertension. End organ damage, as I told you, will lead to LV hypertrophy and heart failure, renal damage, arterial stiffness, and endothelial dysfunction. And yes, we all know it may be associated with metabolic abnormalities like obesity, insulin resistance, and diabetes. So, sympathetic overactivity is reported to be a key mechanism in essential hypertension, and it has deleterious cardiovascular consequences. A lot of sympathetic activity is found in younger obese individuals, and even in Oman, like the rest of the Middle East, we find young people with sympathetic overactivity, obese, and pre diabetic, which are prone to hypertension. Elevated heart rate beyond 85 beats per minute is linked to sympathetic overactivity, which leads to development of hypertension, especially in younger individuals. Tachycardia and sympathetic overactivity are linked to the early morning peak that happens in ischemic events, mainly myocardial infarction and stroke that happens early morning is mainly due to the sympathetic overactivity and the accelerated hypertension. So what triggers the sympathetic overdrive? It's diabetes, it's mental stress, it's obesity and high BMI, it is smoking and hypertension itself. So, what are the characteristics of the high sympathetic overactivity? So, younger people who have anxiety, panic, nervousness, lack of sleep, inability to relax, palpitation at all the times, breathlessness, high resting heart rate, and high BP and dyslipidemia are the hallmark of sympathetic overactivity in young hypertensive patients. The sympathetic overdrive may be responsible for resistant hypertension, and this could also lead to renal ischemia and kidney hypoxia, hence increased sodium retention, RAS, and a decrease in the renal blood flow, resulting in chronic kidney disease. And on the heart, it may be responsible for LV remodeling, heart failure, atrial remodeling, arrhythmias, increase in the heart rate, and increase in the oxygen consumption, resulting in ischemia to the heart, the wall thickness which increases, resulting in diastolic heart failure. So most global guidelines have recommended sympathetic inhibition as a goal in antihypertensive therapy. And as we know, the hemodynamic and metabolic effects of antihypertensive drugs according to their sympathetic activity. So sympathetic inhibitory drugs are going to decrease the heart rate and the myocardial oxygen demand. It's going to decrease the coronary vascular resistance, decrease the blood pressure variability, decrease the insulin resistance, and decrease the LV hypertrophy, and also protection to the cardiac and the vascular protection. So if you look at effects of the high blood pressure on the kidneys and the renal function with advancing age, we note in phase 1 there is increase in the renal vascular resistance, and this is because of the atherosclerosis which sets in the renal artery and hence in the afferent and the efferent arterioles, and this may be responsible for release of norepinephrine and angiotensin. And in phase 2, there will actually be a functional and structural disturbance in the renal vasculature, but still there could be a normal creatinine with a preservation of the EGFR, but there will be microalbuminuria. And later on, with the increase in the renal vascular resistance, there will be structural involvement of both the renal vasculature and the glomeruli, resulting in arterial and nephrosclerosis with decrease in the perfusion to the kidneys and hence hypoxia of the kidney. And in phase 4, there will be increase in the capillary pressures in the glomeruli, which may be responsible for the nephrosclerosis, the glomerulosclerosis, and then the proteinuria. And the final phase would be CKD. Why I'm covering so much of the kidney? Because the new molecule today, and which is cilnidipine, would also have a renal benefit. So as we go around the presentation, I'll tell you on the cardio and renal comorbidities, which are very well treated. I myself has a large experience with this product, and this has been my favorite product for control of hypertension. I give in the dose of 20 milligram OD or BID to patients, particularly when I suspect hypertension with LV hypertrophy and with a CKD with a rising creatinine, or sometimes when I suspect that the patient will have nephrosclerosis with arterial atherosclerosis. So if you look at antihypertensive therapy and chronic kidney disease, the progression of CKD depends on the level of the blood pressure control, the degree of the proteinuria, and underlying kidney disease, including diabetes, because diabetic kidneys with proteinuria and hypertension is a bad combination, and the previous rate of GFR decline. So we need optimum therapy as doctors to control and give optimum blood pressure to our patients. We also have to protect their end organs. We have to protect their heart, their kidney, their eyes, and their brain, because this becomes a very important part in the treatment to target these end organ damage which happens. So management of hypertension began in 1960s, and we know the old drug hydralazine and reserpine. 17, we had a combination of diuretics, and then we had RAS blockers with diuretics, beta blockers with diuretics in the 80s. 19s came the RAS blocker, and then with the calcium channel blocker, which is amlodipine. And then in 2000 to the present, we had the calcium channel blockers, which started with amlodipine, but then we had a lot of fourth generation and third generation calcium channel blocker, and cilnidipine had been the fourth generation calcium channel blocker, which has its lot of benefits. Recently, we also have triple combos. I don't know whether in Oman we have availability of triple combos, but in India and also in the US now, we have been using combo therapy as a single therapy because of compliance is much better. could be a combination of the fourth generation calcium channel blocker with a RAS blocker, which may be an ARB, like olmesartan or telmisartan, and with a diuretic. So this is the first generation. We started with nifedipine, short duration, more adverse effect with nifedipine. All of us know nifelat produces reflex tachycardia, and patients start flushing with use of nifedipine. So in the cath lab, as an emergency, or in the ICU, we may just keep a nifedipine 10 milligram jelly under the tongue to reduce systemic hypertension. Second generation was felonidipine and benidipine. Third generation was amlodipine and also azelnidipine. And I find azelnidipine and the fourth generation silnidipine are very much alike, but there are certain points on which silnidipine actually scores over azelnidipine. But amlodipine in a hospital prescription is almost a no-no now because of pedal edema, reflex tachycardia, palpitation, and also proteinuria, because it dilates the afferent arterioles in the kidney, but it actually constricts the efferent arterioles. Therefore, it produces a gradient between the afferent and efferent arterioles, and this produces kind of effect on the glomeruli, and therefore it doesn't protect the podocytes. Hence, the glomeruli start leaking proteins because of the injury to the podocytes. So large number of people of amlodipine will also have pedal edema besides the palpitation and the reflex tachycardia. So this is the evolution of the calcium channel blockers. We started with diltiazem and verapamil, and we went on to the recent renoprotective silnidipine.